Well, good morning, everybody. What I'm going to be talking about this morning is you and your healthcare professional, signs of potential problems, how to avoid them. I'm not going to be covering how to treat those problems. Those are going to be covered in different sections. And let's get the next slide up. Now, you and your healthcare professional may love each other. I get a great kick out of seeing some of my patients at Costco, in the park and everything. I would rather see you there, but I really do not want to see you in the emergency room for something that we could prevent. And the first step to doing that is learning how to recognize potential problems and either stomping on them early or knowing what you can do to prevent them from happening. Okay, there's two basic groups of potential problems, those related to enteral access and those related to parenteral access. In enteral access, my favorite thing is the three bears. Remember, it's too hard, too soft, and just right. And the biggest problem a lot of people have with the feeding tube is how close that tube is supposed to fit to the skin. If it's too tight, and there you got your father bear with his submachine gun, ready to take care of it, you can get what's called buried bumper syndrome, where it's going to go into the skin. If it's too loose, you can leak around the tube and have problems. We're going to discuss what those look like. You want it just right. Too tight. Here's a picture of what buried bumper syndrome is. If you have to remember, with your gastrostomy tubes, there's a little flange or a balloon, depending on the type of tube, inside your stomach, inside your child's stomach, inside your stomach. And that's what keeps it from falling out. And the idea when you put these tubes in is you want the tube in the stomach to be up against the stomach wall. You want the bumper or the securing ring on the outside to be against the abdominal wall to hold those two together. What can happen is that tube can be pulled up too tight. And we all know these tubes are designed not to just fall out at a quick yank. It takes 15 pounds of pressure for about 10 to 15 seconds to collapse that rubber bumper and have it come out. It's designed that way so you don't actually catch it on your clothes or something, your child doesn't catch it somewhere and suddenly whip the tube out. But if it's chronically too tight, what you see is it slowly starts eroding through the stomach wall like that. And it can actually fall out of the stomach and just be in the subcutaneous tissue. That's called buried bumper, and it's too tight. Too loose, I gotta push both of them. Too loose, and you're gonna get leakage around the tube. Now, stomach contents are irritating. I'm sure every one of us at some time has thrown up, whether you're on tube feeds or not, and you know that burning feeling in your mouth. You know people who chronically are vomiting, they'll damage their teeth. Stomach contents, even in somebody who doesn't have a fully functional stomach, are erosive. They're irritating. And if you have chronic leakage, you're going to get skin breakdown, like you see on those pictures. That's going to cause your skin to continue to break down. It's going to cause your tube to get looser and looser because your body tries to withdraw from the tube at that point, and you're going to get more leakage and ends up losing the tube. So what do we do about that? Just one more thing on too loose. When it leaks, we've tried a lot of ways of giving people tube feeds. I have never found anybody successfully fed yet when you dump the tube feeds on the abdominal wall. It does not work. Be nice if it did, but you have to be able to get them into the stomach. So what's just right? And I tell my patients, use the analogy of a well-functioning faucet. When you have a gastrostomy tube, we all know you don't want your faucet handle to go winging around. If you start to turn it, you just don't want to go and spinning, and you don't want to have to force it to turn it around. You want it to have a little bit of resistance and then slow. That's the amount of resistance you want. When you have a gastrostomy tube, you want to be able to slowly turn it, and it should feel about like a faucet. Now, just remember, jejunostomy tubes don't turn. So don't take your child to your jejunostomy tube and start trying to turn it. That's not going to happen. Now, why won't your tube fit properly? Tubes that are too tight, the number one issue is weight gain. Now, everybody says, my child's gaining weight. This is wonderful. I'm putting on weight. This is fantastic. But that means you have to adjust the outer flange. Depending on your tube type, it may be the short one where it's a silastic flange that's right up against the skin. You may have to go and have a longer flange put in. It's getting tight. If you've gained weight and the bumper starts slipping, In other words, some of them have a little silastic ring around it, or if you saw in that earlier picture, let me go back and show you that one again. See that ring there on your skin? That can come loose and it can start slipping back. So the bumper can start slipping. Too loose, you've lost weight, and now you've got a gap. So now you've got to sit there, possibly slide that bumper down, or get it, if it's all in one piece, get a shorter flange. The bumper can't, again, and the other thing is if you start to get skin breakdown, your body reacts by trying to get away from the irritation, so it's going to retract away from the tube. And so you have to sit there and change your tube out to make sure it fits. To prevent the problems, mark the tube. That's your tube. It belongs to you. It does not belong to the doctor. It does not belong to the gastroenterologist who put it in. It doesn't belong to the radiologist. That's your tube. That's your lifeline. Get a marker, get a piece of tape, get something, and if you have a bumper that slides, mark where it is. And if it starts to slide, you can either try and put it back, or if it's sliding because it's being pushed away because you're gaining weight, know that and realize you might have to adjust it. And remember the faucet metaphor, just keep it gently turning in there. Other things you want to do, you do want to rotate that bumper regularly, because if it lays against the skin for too long, it can cause pressure sores like a bed sore. It's just going to sit there. And what you need to do is, again, rotate it. And not 360, rotate it 90 degrees. Or 260, not 180. In other words, you don't want it to turn around so the bumper is sitting exactly where it was before. Even if you turned it 90 degrees, you want to get it at right angles to where it was before. And just keep turning it so it doesn't dig in, so it doesn't have that chance to press down. If you're starting to lose or gain weight, let your healthcare provider, and I say that because I've seen a lot of registered dietitians do fantastic work with this. I've seen other healthcare professionals, not just doctors, do it, but let them know, I'm gaining weight. Maybe we need to change this tube sooner rather than later. It's not the correct time slot for a time change, but it's starting to press down. It doesn't turn properly anymore. So that's the time to sit there and say, let's go change that tube now. Let's avoid the problems that can happen. Clogged feeding tubes is the bugbear of everybody. We've all had it come in. Tube feeds, I have on occasion told patients, you're really not supposed to put the steak down the tube. I know that I said you could put anything, but that was anything you could put through a blender. Okay, the usual causes are you didn't flush the tube adequately. And the prevention's flush the tube. In other words, you've got the feeding in there. Once you're done with it, make sure you flush it out. Make sure you've got to the point where it's flowing freely again. The water's going through there. Medications, some people mix them into feedings. Let's get it done quickly. Well, unfortunately, a lot of these medications are not compatible. The worst one I ever saw was there was a solution not used as commonly now. It used to be called Carafate. Yes, I see people in the audience going like this. It was either a pill or a liquid, and the idea is once it hit your stomach, it turned into this gel, and it coated the lining of your stomach, and it was great for preventing ulcers. Well, if you shoved it down a feeding tube mixed with tube feeds, it turned into that gel in the tube, and you were done because you couldn't clean it out. I have a picture, which unfortunately doesn't project well, where you can still read the C, A, and part of the R of the tablet in the tube. I used to have people send me, every time a tube got clogged, send me the tube, and I was cutting it open to see what was in it so we could stop it. And I found pills. You have to be sure with your medications mixed with feeds that they can be mixed. Any medication that says take on an empty stomach, that means stop the tube feeds, flush the tube out, wait 20 minutes or more if necessary for the stomach to empty, then you put the tube feed down, then you flush it out again, then you have to wait for the stomach to empty again. It doesn't mean turn off the tube feeds, push the medication down and put it back on again, because that's eating it on a full stomach. And most of you know this, you have no idea how often in the hospital I've had to explain that to the nurses. Yeah, I see the nurses raising their hands because it turns around and it is a situation where they think, don't mix it with means you can turn it off, shove the meds down, turn it, and it says, possibly they didn't get the medication because it's been deactivated, it's stuck in the tube, we've now clogged up the tube, then we get the phone call and I'm like, oh God, okay, here we go again. Crushing pills are an issue. I will tell you right now, time-release pills cannot be crushed because the coatings are specifically designed to dissolve at a specific rate. Time-release capsules, where you can open them up, can be opened and mixed in because the little microbeads in the capsule will break down at different rates. What you need to do is talk to your provider and ask them, is this medication available in a liquid form? Anything that can be given in a liquid form, that's what you want. And you don't care if it's the pediatric elixir. I will tell you right now, the only difference between pediatric liquid meds and adult liquid meds is pediatric liquid meds tend to taste better. They tend to have that bubble gum and banana, which, by the way, is what I use on my dog every time he needs antibiotics. He much prefers the bubblegum flavored amoxicillin to the meat flavored amoxicillin. He's a crazy little dog anyway. But go for liquid medications. Get the liquids, and again, flush them through. Don't try, and I've seen people do it. They put the tube feed down, they get out the hammer like this, and oh good, this looks good. I was once on an internet talk show, and it was about gadgets, and they talked about a pill shaver. And you put the pill in there, and it turns a little crank, and it's kind of shaved the pills up. And they were sprinkling it all over the applesauce, and I says, that's not a good idea. You have to be sure the pill can be crushed. If you're stuck with it, it's a crushable pill. And if possible, like I said, get a liquid medication. It doesn't make a difference that the liquid is labeled for pediatrics. They work the same. Okay, what you can do at home to unclog your feeding tube. So if you think there's a problem, warm water irrigation. Now, that means drain as much as you can out of your tube, put some warm water in, cork the tube, let it sit a couple of minutes, drain it out. And you can do that almost ad infinitum if you don't put a lot of pressure on the tube. It's not going to cause a problem. There are enzyme solutions commercially available. I will tell you right now, the studies do not support the use of Adolph's meat tenderizer. People have always talked about using meat tenderizer to clear the tubes. The prospective studies that have been done on that say it really doesn't work. There's too many issues. It just doesn't work properly in the tubes. It really doesn't break down fast enough. But there are enzyme solutions you can get, you can keep at home, and you can use that to clean out your tubes. They do have commercial decloggers. They look a little bit like the roto-rooter the guy uses to come and take the tree roots out of your sewer drains and such. They're not approved for home use yet. So officially as a doctor, I cannot tell you, go get one of these and keep it in your house. Unofficially, I'm not going to stop you if you can do it and you feel, I tell all my patients, I says, you're doing something, I can't tell you, don't tell me about it. I don't want to hear about it. But this is how you're supposed to do it correctly. You can talk to your doctor if it's a chronic problem and you all feel comfortable with it. Then you, oh, don't do that to me. I just got a notification to do something. Soda does not work. They have actually done studies on soda. The last study done was almost 25 years ago, and believe it or not, the best soda around was Mountain Dew, which of course will take the paint off the wall and will dissolve anything. It's worse than Coca-Cola. And if you didn't know, hazmat teams do use Coca-Cola to clean up toxic spills because the stuff dissolves anything. But you see people say put cola down the tubes, put, club soda. The theory is that the bubbles and the acids in there are supposed to break it down. The problem is what acid does is it coagulates the proteins, which are usually what's clogging up the tube. And that turns it into gunk, into a gel, and it makes the situation worse. You don't want to use acid. The reason drain cleaners are all alkali is because they dissolve protein, but we don't have a safe alkali solution that we can use. So it just doesn't work. So don't try the Coca-Cola down the tube routine. Occluded central lines. Statistically, over the lifetime, 1 in 4 central lines is going to have a problem that's occlusive. That can be a PICC line, it can be a chem port, it can be a Hickman catheter. It's not relevant to where it comes out of the skin that these lines are going to be occluded. The problems can be from a clot in the line, and we're going to go into what these are and how to prevent them. A fibrin sheath over the tip of the line, something called pinch-off syndrome, which I'm going to discuss. And as I said, there's no tube that's better than the other for occlusions. Different lines, and that's going to be just, you got it. I'm going to pick it up. I'm going to get the hook on me in a couple of minutes here. There's no lines that are better than the others. It's whatever line you and your family are comfortable using. Signs of an occluded line, it just doesn't work. You may get a high pressure warning on your pump. You can't draw blood out. The pinch-off syndrome is when it's caught between the rib and the collarbone, and you get the, well, it works if my arm is up like this, and it doesn't work if my arm is over here, and it really doesn't work if I'm like this, and you get the call from the doctor, we'll infuse it like that. So that's pinch-off syndrome. If you have a clot in the line, it's because you didn't flush all the blood out of it. The treatment to prevent it is inadequate, is to flush it. A fibrin sheath, which covers the top of the line, is from inadequate flushing. Treatment, flush the line. That's not always preventable. Sometimes the body just walls these things off. The pinch-off syndrome, don't go walking around with your arm like that. Get that catheter replaced, because the danger is the catheter is going to shatter in the vessel and is going to migrate. Access displacement, we're going to hit quickly. If you have a young child, nasoenteric feeding tube, or an elderly person, you've got oh, sorry. Sorry. Okay. You want to secure it to the nose, but not so tight that it's leaning up and it's causing an erosion here. The best idea is to keep it between the nose and on the forehead so it's out of line of sight. If it's, most patients, they find if it's out of the line of sight, they don't bother with it much. In babies and elderlies, you can consider mittens. I don't like mittening people if I don't have to. I think it's just not nice. As I said before, G-tubes aren't yanked out. J-tubes normally cannot be pulled out if they're long-term. They have a little cuff under the skin, and you'd be screaming in pain before you're going to pull it. You might break the external part, but you're not going to pull it out. Okay, central lines, PICC lines, the access, the securing mechanism we have are not great. All of them can be pulled out. Oh, sorry. Sorry. Tunneled catheters have the cuff again, which holds on to them, but however, that makes it harder to remove when they have to. Implanted ports can't be dislodged, but the needle can come out. Remember, that needle is only held in by the dressing on the skin. To prevent the central lines from coming out, make sure your dressing is good. I'm going to show you a picture of how to coil it and cover it with a cuff. That is not a recommendation for that particular brand of catheter, but if you notice, it's coiled up under it. The reason for that is if the tip catches, the first thing to come out is that coil. And it gives you those 10, 15 seconds to grab it and say, wait a minute, and stop it. If it's just hanging loose, the pull's directly on the skin. Cuff, keep it covered up, keep everything underneath it so don't catches on anything. Internal dislodgement is when it moves out of position. Anything that increases pressure in your chest can do that. A severe asthma attack, not a cough because you swallowed something the wrong way, but a severe asthma attack can pop the line. A Valsalva maneuver where you hold your breath and strain can do it. This is what I tell my patients, bungee jumping and roller coasters are out. Those can displace lines because of the rapid deceleration changes. The problem is if it moves, you're going to clot off the vessel. Now, picture here, if you notice, this was somebody who went bungee jumping. Catheter went down. If you follow it, it's into the superior vena cava, turns around, flips up, and you can see where the arrow is. It went right back up the jugular on the other side. This is why I say, no bungee jumping. Usually my patients look at me and don't worry about that. Some of the teenagers do. You got it. Some of the signs of dislodging the catheter, you suddenly can't draw blood where it worked before. The big one, if you start to infuse anything into your line and you hear a funny bubbling sound in your ear, that catheter's up your jugular until proven otherwise. Because you suddenly make turbulence in that vessel and you can hear it. I'm a great believer in physical diagnosis and talking to the patients and putting my hands on the patients. That one, I'll get a chest x-ray. Somebody calls me up and says, I hear funny sounds in my ears. And it's not ignore it, it's not forget it, it's go get an x-ray and make sure that catheter hasn't flipped up into the jugular. If your arm gets swollen, because, as I said, the dislodgement causes turbulence. Unfortunately, this isn't fixable by you. There's nothing you can do to get it back in position. You can't go bungee jumping again and hope to flip it back where it belonged. I wouldn't go bungee jumping under the best of circumstances. I do not trust my life to something I used to use to hold my books to the back of my bike at college. I'm going to very briefly touch on infections because I know that's being covered. Infections are the big issue with losing your lines, losing your access. You can get infected on enteral from skin erosions, from leakage, parenteral. The source is bacterial contamination. Number one is the hub. That hub is gold. It is precious. You do not want to touch it with your bare hands if you can. Other infections come from your skin. Others can come from remote sites. I will tell you right now, almost nothing grows in parenteral nutrition. The osmolarity is too high. You can occasionally, if there's lipid in there, get fungus growing in it, some gram-negatives, but the normal things you see, the infectious bacteria, staph strep, don't grow in TPN, so that's not where it's from. Okay, I think I'm being told to knock it off.
Right before the floor opens up and you go down.
Mm-hmm.
Is now.
Okay. Okay.
Stay here because we have questions, and I think our friend from Australia has a question.
Trampoline.
Oops. I'm sorry, what?
Trampoline.
Probably not enough. The shock on a bungee jump is at least 3G. I don't think a trampoline, as long as you got the catheter secured so you're not going to catch it on the trampoline. On the other hand, kids do break their necks and stuff on trampolines, so I think you have to decide on that one yourself. But any activity, you want to make sure that particularly with teenagers, with kids who are running around, they're doing everything possible. They want to be as normal as possible, and I encourage them, you've got to get out and do everything you can do. You got to make sure that catheter's secured and out of the way, where they can't accidentally catch it.
Other questions? We've got the mic coming up.
I found your speech extremely interesting. Oh, I'm sorry. I found your speech extremely interesting. And I was wondering if you can differentiate taking meds on an empty stomach with a J tube versus a G tube. I wasn't sure whether you're giving the same directions for it didn't matter which one, or it does matter whether it's a G tube versus a J tube, because with a J tube feeding, nothing is going into the stomach.
The problem is a very good question, G-tube versus J-tube medications. The small bowel is rarely empty. You really can't make it an empty stomach like you can. You also have to check a lot of the medications, and I know we have some pharmacists in the audience, their mode of action is dependent on them being first hit by stomach acid. And they may not work properly if they're put directly into the small bowel. So that's something you have to, your dosage may be different, they may be better absorbed, they may be less absorbed because they're not exposed to stomach acid. But it's my opinion, it's really impossible unless you wait 6-7 hours to get the small bowel empty. If you have to give it, then I would just make sure you flush that tube out very well, put your medication in, flush it out again to prevent it from precipitating in the tube and clogging up the tube.
Okay, so how about putting in, when it's on empty stomach, can I put medication into my G tube even though I'm fed through my J tube?
Yes.
And is my stomach considered empty then all the time?
If there's no food going into your stomach is considered empty. What you're worried about when you're feeding somebody not on an empty stomach is that the food content, particularly the protein, is going to interact with the medication, can bind it up, can deactivate it. I'll tell you a classic is tetracycline and anything with calcium. Remember how they always told you, took tetracycline, you couldn't have dairy because it binds to the calcium. So what you're worried about is that it's going to bind to something you've eaten, which will either deactivate it, speed up its activation, change its mechanism of action. If you're not eating anything, then your stomach, but make sure also then your stomach empties properly. If you're not eating, if you're not being fed through a G tube and a J tube, you have to make sure your stomach is emptying so that the medication gets where it needs to go.
Okay. Another question is I didn't hear anything about granulation tissue. And I find that to be, I find it to be very painful and annoying, and most of the time my doctors just dismiss it. They give me silver nitrate to put on it or zinc oxide, zinc ointment, and really neither of them really are very effective.
Granulation tissue is a normal response of the body to an open wound, not necessarily to a cut, but when you have a raw surface. And some people make thicker scars, some people make more. What your doctor's giving you, the silver nitrate stuff, is to burn it off. And sometimes it works, sometimes the granulation tissue just comes right back. Sometimes, I had one patient who got granulation tissue in one arm, and we switched the access to the other arm, and it didn't happen in the other arm. But unfortunately, it's like any kind of scar formation. There's no way to guarantee that it's not going to happen. And the treatment, as you've heard, is local. It's basically to try and cauterize it, to use silver nitrate to burn it off.
Okay.
Hi. When you spoke of the dislodgement of the central line, sorry, right here.
Right here.
you spoke of coughing. Do you ever see it dislodge with extreme vomiting or retching?
I haven't seen it yet. It certainly can be the same mechanism of action. She has to, in other words, extreme coughing. As I said, coughing is not, it's somebody who's having a severe asthma attack. They are just coughing, they can't clear their airway, their face is turning red. What you're doing is something that really dramatically increases the intrathoracic pressure, and you can pop that line out of position. Yes?
One more?
Two more.
Joan, right up here.
Mm-hmm.
Even though I flush very carefully and very extremely, at about 2 years old, my catheter we'd flush it, and I'd be in the hospital the next days for them to have to run through and clear it, and it seems that the catheter itself would just adhere to whatever it was, even though I was flushing, 4 or 5 salines before I put the ethanol lock in, and you get it going, and then it would be stiff when you try flushing it the next time, and then you couldn't.
Unfortunately, you're talking about intravenous catheters,
Oh,
correct? Yeah. Unfortunately, what happens is the body will react to any intravascular device by wrapping it in fibrin. It's the body's attempt. And some people, that fibrin just comes right over the tip of the catheter. And what you can see is a valve effect, where you can infuse and you can't pull back because the second you try sucking back on it, the flap comes down. The ethanol lock and everything is great for preventing the lumen of the catheter from getting occluded. It doesn't do anything for the fibrin sheath on the outside. They have tried heparin-impregnated catheters. They've tried a lot of stuff. None of it really works effectively.
So
I got.
a certain length of time your body's going to tolerate it, and then you got to change the lock.
I send a lot of my patients home on PICC lines. I routinely change them at about a year time if there's no problems. So maybe I'm just avoiding.
You get access, we hang on to it with dear life.
I'm lucky I've got a very good interventional radiology team who can get access on so far just about anybody, including patients they've almost completely occluded.
We have a question on this side.
Hi, I got one question for you. I'm on TPN 7 nights a week for 12 hours a night, and I take multiple medications every day, morning and night, orally only. I don't put anything through a line or a tube. Part of them are take on an empty stomach, part are take however you want. I don't really have a way to empty my stomach that way. I mean, I'm always eating. What would be a good way to do that? I mean, are there complications that can arise from that?
As I said before, on an empty stomach means no food.
Right.
It doesn't mean that you don't have your normal gastric secretions, the mucus your stomach secretes, the acid, depending on the level of functionality. Medications on an empty stomach are designed to deal with that. What they don't want it to come in contact with is protein, calcium, sugars, and stuff that you would be eating. So if you're not eating anything, your stomach is functionally empty. As I said, my concern on anybody who does that is you want to make sure your stomach empties properly, that the medications are going to get where they need to go.
And it doesn't matter about the TPN. That doesn't interfere with.
Right.
Well, I'm new to it, so that's why I asked.
Well, TPN doesn't, I've had patients that say it doesn't go in your stomach. And some people don't understand that. Yes, one more question.
Could you just clarify that medications should never be crushed and put down their central catheters?
No, not central catheters.
Yeah, I'm just asking. Yeah, right.
Yeah.
I just asked you to clarify that.
No, we do not crush pills and put them down an IV line. I did have a resident try that once. That resident was hanging by her thumbs from the flagpole when I was done. It was like, no, we don't do that. The point is, when I was talking about crushing, you have to make sure the pill is crushable. Check with your pharmacist about that. Some of them are not. A lot of them, in fact, the time-release ones are not crushable, and that they're going to function the same if you've crushed them. That's what I'm saying. Talk to yes, Enteral. Talk to your pharmacist. See if there's a pediatric liquid equivalent, and just use it. It's not going to hurt you to use the bubblegum-flavored medication down your tube.
And always check with your physician, your medical provider, before putting anything in place, regardless of what you've heard from anyone or read.
Well, thank you very much.
Thank you.